presyncope. So these are the four important terms which can come under dizziness. So the first step in evaluation of any patient who comes with the dizziness to put in which of these four groups the patient is in, because that will decide the future management of that particular patient. So diagnosing the cause of dizziness is going to be a little more difficult because the symptoms are non-specific and the differential diagnosis is very, very broad. But nevertheless, a very simple history, a good history taking and a good physical examination many times will narrow the possibility of the basic diagnosis. Why this topic is very important is that so more than half of the patients who are presenting to primary care physicians complain of this syndrome, complain of this particular symptom, and most often, as Dr. Jyoti Maypal said, we take them easy, we take them a little bit of tiredness, nutritional problem, and simple fatigability, and give them 1 or 2 pints of fluid and so on. So, having given you some type of introduction about dizziness, I'll go to the types of dizziness. So, the most common cause of dizziness is vertigo, by which we mean false sense of motion or possibly spinning sensation by oneself or his surroundings. There is a commonest cause of dizziness. Then we come to disequilibrium, where the patient feels off balance and also unsteady. The presyncope is a feeling of losing unconscious, impending loss of consciousness is called presyncope. And of course, we have lightheadedness or a non-specific dizziness, where the patient is going to present with vague symptoms and not actually connecting with the environment. As far as the incidence of the dizziness is concerned, the most common, almost 50% of your dizziness is going to be vertigo, followed by almost equally by disequilibrium and presyncope. So when you look at this particular slide about the patients presenting with the dizziness in a primary care dizziness clinic as well as in emergency room, the most, as I told you, the most common cause of dizziness in any portion of this particular classification is going to be vertigo. So in vertigo, as you can see, in any portion of this particular classification, the patient is more than 50% of the patients who present with the giddiness is going to be there. And in this vertigo, the most common cause of vertigo is benign positional vertigo. So the next dangerous cause of dizziness is a presyncope. And most often, these presyncope patients will come directly to the emergency room. Whereas then we have a non-specific dizziness where there is a psychiatric disorder. And of course, what I want to tell you is the most common cause of a particular benign positional vertigo. And most of the patients with the presyncope will present in emergency department. So the most common cause and the most dangerous cause, and that's why we have to approach a dizziness. So let us look at how we are going to approach this non-specific term of dizziness. So the most important thing is the assessment by clinical history and examination, which most often will give you the etiology of dizziness. So we are told you the most common cause of dizziness is vertigo, followed by presyncope, the psychiatric disorder, and disequilibrium. So I told you these are the four important groups of dizziness, and the most common being vertigo. So as I told you, simple history like positional changes in symptoms, orthostatic blood pressure measurements, the pulse changes, and observation of the gait, detect of nystagmus are the most important physical signs and the history, which will most often make you understand why this dizziness is happening and try to put them in any one of these four groups of dizziness. That's why the clinical assessment, which includes the history and also the clinical examination, and also the history is not only from the patient, the history is also from an onlooker who is witnessing that particular patient is undergoing dizziness is important. So there are few important key questions which we call as a dizzy history is to describe the first episode of dizziness. So we have to, most important thing is whether the objects are spinning either by himself or the surroundings are spinning. This will give a very important clue regarding the vertigo, whether they are occurring in attacks or continuous. That will give you episodic or paroxysmal or continuous. That will give us the narrow down the etiology of dizziness. The most important thing is the positional change. Whether the positional change is going to precipitate the dizziness, that will get us into most often into either presyncope or into vertigo. So we can tell them, ask them when it is starting, whether you can stand unsupported. So what will stop dizziness? Whether you are lying down, it will stop the dizziness, or you stand still, not moving your head is going to stop dizziness. So what is going to make it better? What is going to make it worse? So these are the simple clinical history which will give us some data regarding the diagnosis of dizziness. I start with the most dangerous form of dizziness, which is called presyncope. The presyncope is sense of impending loss of consciousness. The patient feels as if he's going to lose consciousness, but he's not losing consciousness. Before that, he regains the consciousness. But the most important lesson is, or the practical implication is that the presyncope has got the same significance as a classical syncope. So we can say it is an aborted syncope. So it is primarily because of the episodic diffuse temporary cerebral ischemia, and the most important clinical signs you can witness during presyncope is sweating, and the most important clinical sign is pallor, and the patient says that his vision is usually going into telescoping. That's a very important issue to tell that the cerebral ischemia is happening. So as far the presyncope is concerned, as I told you, it is a prodromal symptom as if the patient is going to lose consciousness or a near faint. We must understand the presyncope is much more common than syncope. That's why we miss this symptom. And classically, the patient, and we do not investigate and treat, and the patient stands and the patient ultimately develops syncope. So it can last for seconds to minutes only. That's what's very important. It may not last for hours. Presyncope is only for seconds and minutes, and nearly blacking out or nearly fainting is the symptom given by the patient. So the patients are less intense, it is going to confuse you, but if the patient is going to be classical presyncope, it is very easy to identify the primary history itself. So the patients with the presyncope, because of the cerebral ischemia, they can have lightheadedness, feeling of warmth and diaphoresis because of the increased sympathetic activity, and they can also have a visual blurring because of the reduction in the blood flow to the brain, and occasionally it can also to the blood to the eye also, they can also have a blindness. The most important clinical sign, or the important clinical sign, is the pallor by the onlookers. During the patient is developing a presyncope, he goes into a severe pallor. So this presence of a pallor during that episode of dizziness may direct you that this patient may have a presyncope and not anything else. So that's why it's very important to ask history, not only from the patient, but also from onlookers who are witnessing that particular episodes of dizziness. So most often the presyncope occurs when the patient is standing from the lying posture or sitting upright and not when supine. So when this type of presyncope is happening, you must most often think of postural hypotension. But sometimes the patient can have presyncope without all these maneuvers. Then you must think the presyncope is due to arrhythmia and not necessarily due to postural hypotension. So presyncope itself, the two important causes are that the postural hypotension and also due to cardiac arrhythmias. Postural hypotension can happen in standing, whereas the arrhythmia syncope or presyncope can happen at any position. So the most common cause of presyncope is a postural hypotension, which is defined as the fall of 20 millimeters of systolic and 10 millimeter of diastolic when the patient is standing after 5 minutes of supine position. So the BP may usually up to 3 minutes, and the most important advice is don't start any antihypertensive or increase any antihypertensive without checking postural blood pressure in elderly. So when you check the blood pressure from the first minute to 3 minutes, That also give you a clue why this postural hypotension is being present. If the postural hypertension is going to immediately come on standing, it is most often due to drug induced, just like your vasodilators induced or antihypertensive drug induced, the postural hypertension is going to come immediately. Whereas the postural hypertension is going to be manifest around 3 minutes, second or third minutes, is most often due to autonomic nervous system failure, improper sympathetic activation, which is actually producing this postural hypotension. So that's why you have to first of all decide it is postural hypotension, and how to do that is the correct measurement and the correct time. And also you must also note whether it's immediate postural hypertension or a little bit delayed postural hypertension. Remember 3 minutes. So many of the drugs, so most important drug history is when the patient has got a presyncope, especially when the patient has got a presyncope due to postural hypotension. Many of your cardiac medications, all vasodilators, even beta blockers, sometimes vasodilatory beta blockers, clonidine, nitrates, all these things can produce postural hypotension. Central nervous system disorders, the antipsychotics, opiates, Parkinsonian syndromes, a very simple, what we think as innocuous drugs, baclofen, a muscle relaxant, can also produce postural hypotension, which we commonly use when the patient comes with musculoskeletal pain. Tricyclic antidepressants can cause the postural hypotension, and many times the people who are taking the phosphodiesterase 5 inhibitors like sildenafil, and also people are taking the medicines for prostates, they can also develop postural hypotension. So the most important thing is to identify postural hypotension as the cause of presyncope. Once you decide postural hypotension, always look carefully and go through the entire drug history the patient is taking, because just removal of the drug from that particular patient will solve the issue. So as I told you, the most important thing you must understand, the presyncope has got the same significance as syncope. So we can say the presyncope is an aborted syncope. So whenever the patient has got presyncope, you have to look at the onset and offset. That will give you an idea what is causing this syncope or presyncope. So the patient has got an abrupt onset of impending loss of consciousness, and abrupt onset and offset, it is likely to be cardiovascular. So whenever it is a cardiovascular, whenever the presyncope is exertional, it is most often due to obstructive lesion like aortic stenosis, hypertrophic cardiomyopathy. And if the patient has got this presyncope related to a vasovagal attacks or a neurocardiac syncope, whether this presyncope is related to emotion, a particular event, or a situation like a cough syncope or a mixolysin syncope, it is likely to be neurocardiogenic syncope. As I told you, the vascular syncope, once again, postural hypotension. So when the presyncope is not related to exertion, not related to event, emotion, or the situation, the presyncope is occurring at any point in time, at any posture, it is likely to be arrhythmic syncope, or a presyncope, it can be due to bradycardia or a tachycardia. In contrast, that if the presyncope is slow onset and slow offset, it is likely to be hyperventilation, hypoglycemia. If the patient has got abrupt onset of syncope or presyncope and it is slow offset, even after regaining consciousness, the patient continues to be drowsy, then it is likely to be a seizure disorder. So this is like a simple approach to a patient who's got a dizziness due to presyncope. Most often you must understand that the presyncope is the classically described or acted by Bill Murphy here, that he see that eyes are rolling up and is losing consciousness, is trying to lose consciousness. He may lose consciousness, it is syncope. He is not losing consciousness, pre-syncope. But what is the importance of syncope is that, so when you compare the syncope and sudden death, in one, the patient wakes up, in one, patient does not wake up. So that's why that a bit of importance you must give to syncope. A syncope is most often maybe an aborted sudden death. So then we come to the second form of dizziness, which is disequilibrium. It is a perceived postural instability involving the legs and trunk, where the patient has got a lot of difficulty in walking. So there is an imbalance and also disequilibrium. Here the most important clue, the vertigo is absent. I told you the vertigo is a spinning of oneself or the surrounding. So this may not be there, but the patient tried to tell you it's a dizziness because his walking is not correct, and his walking is little bit of irregular, is not able to move the trunk properly, and also the imbalance and equilibrium. So most often this disequilibrium can be due to musculoskeletal disorder interfering with the gait. It can be rarely due to vestibular disorder, cerebellar disorder, or cervical spondylosis. I tell you something about cervical spondylosis. The Parkinson disease patient also can have this. All this patient will come and tell you dizziness. But the most important thing is the inability of the patient to maintain a posture, or the inability of the patient to walk in a uniform manner. Tells you it could be without vertigo. Tell you it can be a disequilibrium syndrome. So the Parkinson patient may have multiple etiology for disequilibrium syndrome. The central nervous system disorder itself, but then it also can have a presyncope due to postal hypotension because of the autonomic imbalance. Most often, the regular our mindset is whenever there is patient comes with vertigo, we most often attribute that to cervical spondylosis. But please remember, cervical spondylosis, if at all it can cause only disequilibrium because of the involvement of the postural control involved by the nerves coming through the cervical spines. But it can never as a cause of vertigo. It is not also accepted as a cause of dizziness. The disequilibrium can be aggravated by the visual impairment. Any underlying eye disease, it can cause also disequilibrium, and also it can happen due to central nervous system disorders, let's say cerebellar disorders. So when you have a cerebellar disorder, it is primarily abnormal gait, dysarthria, the eye signs like nystagmus, and also poor smooth pursuit and downbeat nystagmus. So the nystagmus with abnormal gait, or then it will tell you it can be a cerebellar disorder. When the cerebellar hemisphere is involved, you can have the incoordination or finger to finger incoordination in the lips. So this is how the disequilibrium. Most often we have to think of a neurogenic cause or a peripheral muscular cause, and very unlikely this patient is going to have a classical vertigo or spinning. So then we come to the last aspect of our not last aspect, but the next aspect of dizziness is non-specific, where you cannot put the dizziness into any one of the four forms I told you, like presyncope, disequilibrium, or vertigo. There are vague complaints. These people are healthy and young individual, no deductible diseases in any systems, waxes and wanes around 20 minutes, and most often this dizziness is associated with a deep sigh. Most often it is due to psychological disease. So if you want to make sure this non-specific dizziness is due to actually hyperventilation, we make the patient hyperventilate, and if the patient becomes giddy during the hyperventilation, you know it is a cause of dizziness rather than any other organic cause. The most important clue is deep sighing. So the non-specific dizziness patients will keep on deep sighing, and the purpose of doing hyperventilation to make the patient dizzy and confirming that it is a psychological cause which is causing the dizziness. So once the patient get convinced there is no organic cause and psychological cause, and you try to get out of that anxiety and hyperventilation. And what is very important is during the non-specific dizziness diagnosis, you must not miss an organic cause. For that, what you have to do is when the patient is deeply hyperventilating, you must always look at the eyes for nystagmus. So that's why if you think it is a non-specific dizziness and you keep watching the eye and that eye has got nystagmus, it can never be a non-specific or psychological dizziness. It is likely to be a vestibular lesion. So that's why although you think it's a non-specific dizziness and a psychological, what is very important to look at nystagmus. So then next category of dizziness is dizziness in older patients. The older patients will deserve lot of attention because it can happen up to 40% in the elderly patients. When this happens, it's lot of consequences are going to be very, very disturbing and very, very disabling to the patient who is elderly. So risk of fall, fractures, the disability, institutionalization, all these things get precipitated not because of the basic disease of the elderly, but because of just a fall because of the dizziness. So the assessment of a dizziness in elderly is going to be very difficult because they can have a multiple problems. They can have a vertigo, they can have a cerebrovascular disease, they can have some sort of neck diseases, physical deconditioning. They'll be taking a lot of medications. So all these things may precipitate dizziness in elderly, and it is a difficult problem to approach, and you have to look at each and every cause of dizziness in elderly. The other important thing is I told you the visual impairment caused by cataract or the other diseases of the visual impairment is going to actually exaggerate the disability and dizziness. So when we say dizziness, we have to differentiate from all the other causes from vertigo. So vertigo is the commonest cause of dizziness. The 7 non-vertigo dizziness are the anxiety and depressive, which is psychological, disequilibrium syndrome, the two conditions of presyncope of post-MI or post-cardiac lesion are also postal hypotension, and the patient is taking lot of medicines which may interfere with the blood pressure and also the movement. And of course, as I told you, elderly may have multiple causes of dizziness. So these are the big 7 non-vertigo disequilibrium syndromes. So that's dizziness syndromes. That's why it's very, very important to differentiate dizziness into vertigo and non-vertigo. So having finished the non-vertigo causes of the dizziness, then we go on to see what are the vertigo, what is the basically vertigo and how to deal about that. That might be my next half of my program. So what is vertigo? Vertigo is an illusion of motion interpreted as self-movement or the environment. Either the patient feels he is spinning or his surrounding is spinning. So that's why it's called subjective and objective vertigo. Rotating with the spinning of sensing of falling or swaying back and forth, it can be called merry-go-round effect. And this is the most common cause of dizziness. Almost more than 50% of your dizziness patients will have vertigo. That's why this important history, whether the patient feels as if he is spinning or his surrounding is spinning. So it is primarily arising from the asymmetry of the vestibular system. What we mean by vestibular system is vestibular apparatus in the inner ear, vestibular nerve, the nucleus within the medulla, and also the connections to and fro from the vestibular portions of the cerebellum. So all these things are involved in vertigo. So that's why all the structures are involved in vertigo. The vertigo can be one or more of the structures I have mentioned just now. So the most important aspect of approaching vertigo is to know whether it's a peripheral vertigo, which involves the structures not part of the central nervous system, most frequently in an area called peripheral vertigo. Whereas whenever the patient has got involvement of the brain involved in the central nervous system, which can be brainstem, cerebrum or cerebellum, then it becomes central vertigo. The most difficult part of approaching vertigo to know whether it is a peripheral vertigo or a central vertigo. A peripheral vertigo may not have that amount of prognostic implication, but if you have a central vertigo and you miss that and treat that as a peripheral vertigo, you have a lot of bad consequences which may follow. So now we come to the important etiologies of peripheral vertigo and a central vertigo. The 3 important causes of peripheral vertigo, the commonest is being benign paroxysmal positional vertigo, which is called BPPV. BPPV. So this is a brief position evoked vertigo, episodes of abnormal presence of particles in semicircular canals we describe it subsequently. Meniere's disease because of the excessive endolimb, vestibular neuronitis because of the vestibular nerve inflammation, whereas acute labyrinthitis, infarct, and all the other things are less common. So the 3 commonest causes of peripheral vertigo are BPPV, Meniere's disease, and vestibular neuronitis. Whereas when you come to the vertigo due to central causes, the most 2 important causes are vestibular migraine and of course the vascular disease, which involves the vertebrovascular system, which is going to affect the blood supply to the brain and also the cerebellum. Of course, multiple sclerosis, all the central ornaments are less common. So I tell you three important causes of peripheral vertigo. I give you two important causes of central vertigo. So, as I told you, the vertigo can be called a subjective vertigo when the patient feels himself or herself is moving or spinning. Whereas himself or herself is spinning, it is subjective. Whereas the patient feels he is stationary and the surrounding is spinning around him, this is objective vertigo. Both has got the same implication, but there are two types of vertigo. So understand the vertigo, especially the peripheral vertigo, we must understand the inner ear. How does it maintain the balance and how does it make the patient live without dizziness or a vertigo? So we have what is known as the inner ear has got a vestibular system. We have explained what is vestibular apparatus. The vestibular system includes the vestibular apparatus. So what the part of vestibular system is vestibular apparatus. What we mean by vestibular apparatus is this. Vestibular apparatus has got the vestibule itself, which is utricle and saccule here, and they have three semicircular canals, anterior, posterior, and horizontal. And inside this semicircular canals is the endolymph. The movement of the endolymph according to the posture is the one which is going to convey this movement signals to the vestibule and also to the vestibular nerve, which actually carries the signals to the brain, and the brain is going to act according to the movement of the limb, according to the posture, and adjust the muscles and bones to attain a particular posture without getting a vertigo. So these three things are involved. One is the semicircular canals, which are called the sensors. They sense the motion according to the motion of endolymph in these three semicircular canals. Then we have the nerve, which is a transmitter, which is carrying this abnormal movement of the limb, endolymph inside the semicircular canals to the brain. So this is a transmitter. And of course, three is the analyzer and also the responder. It is not only analyzer and responder. Is the brain, which is, we told you, the brainstem, cerebellum, and sometimes cerebrum. So according to the signals received by the movements of the endolymph inside the semicircular canals, and it is going to adjust our body so that the body balance is maintained, there is no dizziness and there is no giddiness. So these three important organs should be acting in collision and acting with a cooperation and acting with a consensus so that the patient maintains a normal posture, normal walking, normal running without developing a dizziness or vertigo. So we have a sensor, we have a transmitter, and we have an analyzer and also the effector. So this is about an understanding of the three important structures which are involved in the development of vertigo. So as far as the vestibular system is concerned, so when you look at the inner ear, it has got a vestibular system. So the vestibular system is primarily the utricles, saccules, and also the semicircular canals are primarily involved in the maintaining of the balance of the patient, whereas the cochlea is primarily involved in the hearing of the patient. So this is how we have to differentiate the inner ear, which is maintaining the balance and which is actually responsible for your hearing. So when you come to this etiologies and we classify them according to the sensor abnormality, transmitter abnormality, and the analyzer abnormality, the vertigo related to the inner ear, which is called the sensor abnormalities, the most common being the benign positional vertigo. I told you about the Meniere's disease and also I told you about the endolymph problem, labyrinthitis, and so on. Whereas when you come to the problems which is related to the transmitter, which is related to the nerve, which is cause the giddiness is going to be vestibular neuronitis and a nerve compression due to a tumor. So that is the relation, and that is a vertigo due to transmitter. Whereas when you come to the vertigo related to the analyzer and also the responder is the brain, is the demyelination, the most common being vertebrovascular insufficiency, followed by the migraine, where although your inputs are coming appropriately, your brain or the analyzer is not acting appropriately to maintain the balance and also the position of the patient. So etiologies can be also divided into the vertigo into a sensor problem, transmitter problem, or analyzer problem. Most often, whenever it is a sensor problem, it is called peripheral vertigo. Whenever there is an analyzer problem, it is called the central vertigo, and this is the nerve is an intermediate problem. So primarily, we have to differentiate always it is a peripheral vertigo or a central vertigo because the prognosis, the treatment, and of course the subsequent follow-up of the patient is very crucial to make this differentiation, which is most often little difficult. So that's why I am going to go to the next part of telling you how to distinguish vertigo from other type of dizziness. So most often the vertigo can be never continuous. It gets episodic and paroxysmal. So only when the vestibular lesion is permanent. So although the vestibular lesion is permanent, the central system adopts that, make sure that the vertigo is not very long standing. So most often when you have continuous dizziness, you must think of not vertigo, but a psychogenic dizziness. Then depends upon how the episodes are happening. When you have acute prolonged severe vertigo, we must think of vestibular neuronitis and stroke, acute prolonged severe vertigo. Recurrent spontaneous attacks, you must think of Meniere's disease and vestibular migraine. Recurrent positionally triggered attacks, the triggered attacks which is related to the position of the head, it is likely to be benign positional paroxysmal vertigo. When you have a chronic persistent dizziness, it is likely to be psychogenic. So it can be acute prolonged severe vertigo, most often stroke or vestibular neuronitis. Recurrent spontaneous attacks without relationship to the head movement is the commonest is Meniere's disease. Recurrent positionally triggered vertigo is BPPV, and a vertigo which is not confining in any of this presentation is likely to be psychological or a cerebral ataxia. So then we come to the most important part of the differentiating the presyncope and vertigo. So it's very, very important to understand because the vertigo may not, especially peripheral vertigo, may not be life-threatening, whereas a presyncope, where it may be life-threatening. In both, the patient may tell you that as soon as I stand up, I have feeling spinning or giddiness or a vertigo. So whenever they arise from bed, they may complain of this complaint. The key to diagnose whether it's a presyncope or vertigo is this. It all depends upon whether the maneuver you are causing is going to be changing the head position without lowering the blood pressure or decreasing cerebral blood pressure. Please remember, the presyncope is primarily due to decrease in cerebral blood flow because of the low blood pressure. So if the vertigo is going to happening without reducing your blood pressure and cerebral blood flow, it is likely to be vertigo. How to do that? Instead of making the patient from lying to standing, in the lying position itself, if you make him roll over the bed or bend the neck back and forth without making the patient stand up, and the patient's vertigo is precipitated, then you know the vertigo is precipitated not because of the decrease in blood pressure or decrease in cerebral blood flow. You are dealing with purely a vertigo of most often benign positional vertigo, which is related to the head. So that's why it's very important. Whenever the patient feels giddy on standing, ask him to lie down and turn into different positions and change his head. And the change in position on the head make him giddy or vertigo has got a vertigo, then it is unlikely to be a presyncope. So that's what the most important clinical finding to differentiate between presyncope and also the classical vertigo. So when you look at the vertigo as it is most often made worse by moving the head, especially benign positional vertigo. This is a useful feature to distinguish vertigo from all the other forms of dizziness where the movement of the head is not going to be the factor. So that's why a patient who's got a significant vertigo is actually afraid to move at all. So then the head motion does not worsen. If the head motion does not worsen your vertigo, it is unlikely to be vertigo and it is going to be other form of dizziness. That is the most important history in vertigo, whether your head movement or head movement from up and down or sidewards is going to precipitate your vertigo. So having decided it's vertigo with all the other forms of dizziness, as I told you, now we come to the vertigo proper. When you come to the vertigo proper, the most important question is whether the vertigo is peripheral or central. So that is the most important question when you answer when the patient has got a vertigo. So that can be answered by some of the maneuvers and history. So first we look at the general features of peripheral vertigo. The peripheral vertigo, it is the ear involvement. Whenever you have the ear involvement, it is likely to be a peripheral cause of vertigo. So although their absence does not exclude the diagnosis, but most often there will be ear involvement. So whether there is a hearing loss, it is duration, it is progression or unilateral or bilateral, whether there is any discharge or drainage, the most important being some sounds in the ear like tinnitus or lyxia chordatis media. When all these things are present, some ear signs are present with a vertigo and it is related to the movement of the head. Most often you are dealing with the ear cause. When you are dealing with the ear cause and with the ear symptoms, it is likely to be peripheral vertigo. Whereas when you come to the central vertigo, it is a neurological signs which are important. It is not only the vertigo alone, there is an accompanying a neurological sign. The accompanying neurological sign can be easily remembered as 4Ds. It can be diplopia, dysphagia, dysarthria, or dysmetria. So any one of these things are present in the presence of vertigo along with hemiparesis and slurred speech. So the presence of a central nervous system disorders with the vertigo is an important clue to say this vertigo is central. So this is whenever it is a ear problem, it is peripheral. Whenever there is a neuro problem, it is central. So then we concentrate on peripheral vertigo. Peripheral vertigo is primarily because of the vestibular system. The vestibular system is our GPS of our body. So the vestibular system is the car and the vestibular GPS system sends messages to the body. These are the roads. So the neurons which carry the signals from the car to the particular system is the roads, and the destination is actually where you want to go, and of course the base or the ground is the gravity. So it's basically involves not only the inner ear system but also the visual inputs, muscle and joints, motor, and also the hand-eye coordination, tactile. So much of things are involved when you have the balance and when you have the normal position and you have normal walking. So much of interplay is happening between the ear, eye, brain, musculoskeletal system, and all this perception, gravity, all these things are involved in the maintaining of the balance. So these are the important causes of the peripheral vertigo dysfunction. The most common cause is actually listed in the last. It is benign positional paroxysmal vertigo, then followed by the Meniere's disease, then it can be a vestibular neuronitis. So these are the three causes. The trauma and tumors may be uncommon. The three important causes of benign peripheral vertigo are these three, as we have already mentioned. So when you come to the peripheral vertigo due to vestibular neuronitis, it is usually preceded by a viral or respiratory infection. It can be a sudden onset of nausea, vomiting, and severe vertigo, once again changed by the position. It can last for days and weeks, and nystagmus also may last for months and weeks. So most often vertigo related to the vestibular neuronitis is a little bit long duration, and easily it is precipitated by a viral infection. So these are the clues to say that it can be a vestibular neuronitis. So what is Meniere's disease? The Meniere's disease, as I told you, it is the endolymph in the semicircular canals which actually give the input regarding the position of the patient to the sacules and articules, and it will carry to the vestibular nerve to the analyzer. So whenever you have abnormal lymph inside the semicircular canal, so it is called endolymphatic hydrops. There is excessive lymphatic fluid. So naturally its movement is going to be affected. So whenever the movement inside the semicircular canal is going to be affected, an abnormal signal to the brain is going to be conveyed and the brain is going to act wrongly, which is resulting in a giddiness. So it is a spontaneous onset and recurrent attacks due to increase in endolymph, and it can be acting for present for minute to hours. And the most important clue differentiate between a benign positional vertigo and this is the ear signs. Tinnitus, earfulness is a very important accompanying symptom of vertigo. Tell you are dealing with Meniere's disease and also the hearing loss. And it is a chronic recurrent vertigo. So these are the two important things, the ear sounds and also the loss of hearing, along with the classical vertigo is likely to be Meniere's disease. Then the peripheral vertigo can be dogged by many drugs, trauma, and rarely acoustic neuronoma, which is vestibular sonoma. The vestibular sonoma is very rare, but here the very important a rare combination, as I told you, when you have a disequilibrium, you may not have the vertigo, but when you have a disequilibrium plus some sort of vertigo, you must always think of the intermediate problem. The intermediate problem is the nerve. When you have a pure peripheral problem, it is vertigo. When you have a pure neuro problem like Parkinsonism, it is pure disequilibrium. But when you have a nerve problem, you can have some sort of disequilibrium plus vertigo. Then we come to the most important and commonest cause of vertigo. It is called BPPV, benign positional paroxysmal vertigo. This is the most common cause of vertigo, and it is very brief episodes of vertigo, maybe nausea, and there is no tinnitus or hearing impairment. This differentiates the BPPV from actually the Meniere's disease. Spontaneous disasters may not be present, usually self-limited, and rarely it can last for weeks and it can be recurrent episodes. And the most common cause of positional vertigo and most often happens little elderly. And very important history is provoked by the specific head movements. So that is an important history as far as the BPPV is concerned. There is no other neurological sign. Very rarely the patient may have a head trauma. And how to diagnose a BPPV is by Dix-Hallpike maneuver, where the patient's head is turned and suddenly the patient is made lie down so that his head is turned this way and that way. The purpose of doing this is to basically, the benign positional vertigo is the movement of canaliculi, which is actually in the utricle and saccule into the endolymph, into the semicircular canal. Most often, this movement of the canaliculi happens in the posterior semicircular canals. Once this canaliculi happens and comes inside this endolymph, this will actually disturb the flow of endolymph. So naturally, the flow disturbance in the endolymph is going to give a wrong signal to the vestibule and also to the nerve. So the analyzer receives wrong signals and it is confused and is going to produce a lot of abnormal sensations which we perceived as giddiness. So what we do in Dix-Hallpike's method is just to actually make the vertigo disappear by means of moving the canaliculi in the utricle and saccule into the posterior semicircular canal. That's why we do the maneuver. When you do this maneuver, the vertigo is appearing and the nystagmus is appearing. Then you know it is benign positional vertigo because you are displacing the canaliculi from the utricle and saccule into the posterior semicircular canal and you are precipitating. This vertigo means it is a peripheral vertigo, and that is a typical example of a peripheral vertigo. This is what happens. The saccules and has got the canaliculi. The canaliculi, when you rotate the head in Dix-Hallpike's maneuver, it comes into the semicircular canal. It disturbs the displaced octonia, disturbs the blood flow in the endolymph limb, posterior from the posterior semicircular canal. So naturally, the impulse conveyed into the vestibular nerve is going to be abnormal. So that will produce a vertigo. So this is the basic cause of benign positional vertigo, the movement of the octoconia, which is called the canaliculi, from the utricle and saccule. And what you do is you actually stimulate what is happening intermittently during the episode of giddiness, during the episode of vertigo by Dix-Hallpike's method, and that is by you diagnose a peripheral vertigo. And the diagnostic criteria is that the vertigo is precipitated by this maneuver And there is always a latency. It's a very, very important point. It is not as if the vertigo is going to happen or the nystagmus is going to happen immediately when you do this discalpic. And it takes 1 or 2 seconds for this vertigo and nystagmus to happen. And you can precipitate this paroxysmally. And ultimately, when you keep on doing this procedure, the nystagmus disappears. That is an important clue to tell you that it is a peripheral vertigo and not a vertigo. It's a fatigability of the nystagmus. So when you repeatedly do this procedure, these nystagmus disappear, and the fatigability is the important sign to say it is a benign positional paroxysmal vertigo. So these are some of the important differences between peripheral vertigo and the central vertigo. Usually it is a sudden onset, it is a sudden or slow onset. Intense spinning is peripheral vertigo. That's why I told you the patient is afraid to move and it is ill-defined. It is paroxysmal intermittent, most often constant giddiness in a central vertigo, aggravated by the movement of the head in positional vertigo and not here in central vertigo. Nausea, diaphoresis is very, very frequent in peripheral. It can be also vertebral. The most important is nystagmus. The nystagmus is always unidirectional in positional vertigo or a peripheral vertigo, and the fast component of the vertigo, which is called the direction of the nystagmus, is always to the normal side. Unidirectional fast movement towards the normal side, and it can never be vertical. Whenever you have a multi-directional nystagmus, it's a vertical nystagmus, it is most often central. So fatigue of the symptoms and sign, especially fatigue of the nystagmus is going to happen in peripheral and not in central. The hearing loss or the tinnitus may tell you it's peripheral or venous disease. It cannot happen here. Tympanic vein abnormality here, it is not here. And when you have, as I told you, ataxia, when you have a diplopia, I told you 4Ds, when they are present, it is likely to be central. So, to differentiate between peripheral and central vertigo, they have put forward what is called a HINT test, HINT test. The first HI stands for head impulse test. What you do is stand before the patient and ask him to fix the eye towards your face and suddenly rotate his head to one side. So what happens is normally the eye fixation will be there, only the head is movement, the eye may not movement at all. So the eye may not movement, the eye will be looking out. So whenever you have the abnormal head impulse test is that it takes little bit 1 or 2 seconds for the eye goes up and goes horizontally and come back to the original position. There is a little bit of lag time for the eye to come to the original position. That means it is a peripheral vertigo. So this is an abnormal test, head impulse test. It takes a little bit of time. It goes a little bit lateral and comes quickly to face your head is the peripheral vertigo. Whereas the eye does not move at all as the head moves. It is an absent head impulse test and it is most often central vertigo. So it's a very interesting point to say that an abnormal test is telling you a benign lesion. A presence of a normal test tells you a malignant lesion or a little more advanced lesion. So the presence of head impulse test is a very good idea. When you have a lag time, it is most often peripheral vertigo. Then the nystagmus give you a lot of clues regarding the differentiation between a peripheral vertigo and also the central vertigo. The peripheral vertigo is always unidirectional. We can see the most often horizontal. We can see the fast component. The direction of nystagmus is a fast component. The fast component is towards the left side. That means the left side is normal. This patient has got abnormal right ear problem which is causing the vertigo. So that's what horizontal and the fast component and also the fatigability. After some time, these nystagmus may disappear. Whereas in a central vertigo, you have a vertical nystagmus. So whenever you have a vertical nystagmus, it is most often central. So that is the second N. HI is head impulse test. The N stands for nystagmus. If it is fatigable, unidirectional, fast component towards the normal side, peripheral, when you have a multidirectional and any point of whether it's a normal side or abnormal side, the vertigo is happening. Especially the vertigo is vertical and non-fatigable. very number of hours this vertigo is happening, it is likely to be a central origin. So this nystagmus will give you very important clue regarding the central nystagmus. Then we have what is known as the center of skew, which is a little bit complex test, but covering the eye and see whether after suddenly uncovering the eye, whether the eye is moving vertically up. So that the test of skew, when it is positive, it will tell you that it's a central vertigo. So the hint test is a very important test clinically. The head impulse movement and head impulse reflex, the nystagmus and the test of skew is a very important thing whenever the patient comes to you, a severe but acute severe vertigo at the bedside. If any one of this is positive, you must think of a central cause and the patient should go for an immediate MRI. So it is said that the hint test is more sensitive to pick up the posterior cerebral stroke even before MRI. Then we come to the management. I briefly touch upon the management of benign positional paroxysmal vertigo. So the principle is you have an abnormal balance of information from the two vestibular systems to the brain. That's why the brain is confused and is producing the reeling sensation. So the treatment is to correct the imbalance between the vestibular input from the right ear and in the inner ear, right ear and the left ear. So you have two possibilities. The one is depressed and other is normal. So either you have to depress the normal vestibule to the suppressed state so that the imbalance is corrected, or you can stimulate the involved side to the normal so that also the imbalance is corrected. So either you make the normal to be depressed, normal function to be depressed to make the imbalance right, or you increase the depressed side to normal to make the imbalance right or to make it imbalance. So this is a basically imbalance of inputs from the brain from the two vestibular apparatus. So the treatment is to correct the imbalance. The two drugs we do, the cinnarizine and beta histine, act in two different ways. The cinnarizine is going to suppress the intact vestibule, that is a normal vestibule, to the level of depressed vestibule so that the imbalance is corrected. So it is most often antihistaminic. Whereas when you give beta histine, it stimulates the depressed vestibule to come to the normal vestibule. So it actually increases the histamine and prohistamine. See, these are the two important differences. I can tell you the difference by the two cartoons. The imbalance in the vestibular inputs is the main cause of benign positional vertigo. One is depressed, other is normal. So one way of correcting it is to increase the activity of the depressed vestibule to normal by increasing the histamine. That's what your beta histine is doing. What the cinnarizine is doing is to depress the normal vestibular function to the level of depressed vestibule so that once again the imbalance, the basic imbalances get corrected. That is your cinnarizine. So ultimately what you have to do is to maintain the balance between the imbalance between the two vestibular inputs, thereby your vertigo gets corrected. So the best way to immediately relieve the vertigo, especially benign positional vertigo, is not your beta histine, not your cinnarizine. It is a simple maneuver called Epley's maneuver. So this is what many of our ENT specialists do. As soon as the patient gets the vertigo, they do the Epley's maneuver. So basically what you do in Epley's maneuver is that you are trying to make that displaced octoconia or canal ligatures to basically into the utricules and saccules. By this maneuver, why the vertigo has happened? Because your canaliculi has moved into the endolymph. So by this maneuver, what you make is make this canaliculi return back into the utricles and saccules so that you immediately relieve the vertigo. This is the best maneuver to relieve the vertigo. So regular movement or the regular exercise, vestibular exercises actually make sure you are making the canaliculi not to come out of the utricles and saccules in the endolymph and makes it. So when you come to the treatment, a gross improvement in the treatment is that benign positional vertigo is actually what we told you about Epley's maneuver, and labyrinthine concussion is rehabilitation. Next is Meniere's disease, low salt diet and diuretic to decrease the endolymph and rarely the surgery. The labyrinthitis is antibiotics, the infected tissue is removed, rehabilitation, and vestibular neuronitis is a brief dose of steroids. And vestibular migraine is beta blockers, calcium channel blockers, tricyclic amines, vascular disease, as you know, the CVA treatment like antiplatelets, statins, removal of risk factors, and so on. Cerebropontinite, and it is surgery. So these are the treatment approaches to a peripheral vertigo and a central vertigo. So with this idea of dizziness, I come to the summary. So this is a very busy slide, but it can tell you everything about what you have talked about. A dizziness is a non-specific symptom which can be put on presyncope, the most dangerous one. The presyncope, as I told you, is got the same significance as syncope. So most often it can be due to postal hypotension, or it can be a vasovagal attack, or it can be an obstructive lesion where there is exceptional presyncope, or when the presyncope is not related to anything, it can be arrhythmic. So most dangerous, the treatment of the particular cause will have a greater significance, especially preventing a sudden cardiac death. So whenever the patient is off balance and is not able to walk, he sways, and but not a classical symptom of vertigo or is there. Only it is a problem of the movement of the body. It is most often a central neurogenic cause. It is called disequilibrium. Whereas when you have a non-specific dizziness, most often psychiatric disorders, I told you the hyperventilation may precipitate the dizziness, and most of these patients, along with the dizziness, acting, going on very many years and so on, they have deep sighing. So when the patient got a true vertigo as the illusion of movement, self-movement or movement of environment, we have to differentiate between peripheral and central. I told you the peripheral nystagmus, I told you about the hint. The peripheral nystagmus is most often horizontal and the fast component towards the normal side, and there is a little bit of lag time between 40 seconds, and it is very brief and it is fatigable. Whereas nystagmus of the central is horizontal and vertical, no lag time, and it's lasting for long. There is no fatigability here. Whenever you have a auditory symptom, it is likely to be Meniere's disease, and the causes of peripheral vertigo are BPPV, vestibular neurodeminance disease, and acoustic neuronoma. When you have the neurological symptoms of 4D, I told you, diplopia, dysphagia, dysarthria, and dysmetria, along with the hemiparesis and slurred speech, when associated neurological symptom, it is likely to be central, most common being posterior circulation stroke, multiple sclerosis rare, and migraine. Migraine and posterior circulation stroke are the two common causes of central vertigo. But when the patient presents the acute isolated vertigo, with isolated vertigo with a neurological symptom, I told you these neurological symptoms with acute vertigo with a neurological symptom, immediately do an MRI for a posterior circulation stroke. When the patient is coming with acute isolated vertigo with no neurological sign, apply hint, do a head impulse test, do look at the nystagmus and the test of skew, and any one of this is positive, that means it is likely to be a central cause, and do an immediate MRI to diagnose a posterior circulation stroke. So this is how we approach a dizziness, and most often the patients may come any one of these four important classification we may do, and we primarily concentrated on the vertigo, which is the most common symptom and the most confusion symptom, and also the most important symptom to differentiate whether it is going to be a benign problem or it is going to be a problem which has got a lot of prognostic implications. So I end with my talk with this particular diagram. If you are not feeling dizzy with this diagram, check yourself. Thank you for your patience.
Thank you, Chenipan, for that nice, excellent presentation. You have proved you are a great teacher, though this is not your subject. You have dealt in detail, very simple language, everybody can understand. Now we'll go to Kahoot, and after that we'll play that other video also. All of you, please download your Kahoot. We'll have only 10 questions, and after that, whatever questions we have in the chat box, we'll answer. We'll give the game pin number now. Muthu Subramaniam, you can put your questions in the chat box. The game pin number is 853272. 853272. Please log in. 853272. Parameswari Venkat, you can join the Kahoot. Sundarabandi have joined, yes. Sundarabandi usually asks a lot of questions, and he has joined now. Nikhilin has joined now. Ram, I'll give you last 5 seconds.